Yeah, I just needed to see who is here, and I recognize some faces, and it's a great pleasure for me to be here. Thank you so much for inviting me. I just need to get a sense of who I'm talking to before I start with my presentation. The presentation that I'm going to give is really looking at the private sector. And I know there might be people coming from the public sector, and I would just need to get an indication of how many of us are coming from the public sector. Okay, great. So the first part of my presentation is really going to look at the current guidelines. And we know that the beauty now is that the guidelines in the public sector and the private sector have been aligned, even though there are some products that are still not available in the public sector. But I'll touch on those before I go into the newly registered products. Okay. So just looking at the milestones in terms of what has happened within HIV, we know that we have luckily obtained 25 drugs in 25 years, which is something that I think is great for the management of our patients. And if you look at TB management, we have struggled to actually reach that. So if you look at this 25 is only registered products. There are other products that are in the pipeline that hopefully will be registered in the future, but I think we're making good progress, and we're going to discuss those products that have been recently registered. So if you look at the different drug classes that we have now, we've got the NRTIs. Most of you will be aware of the drugs that are in that class. The one that I've actually highlighted in red is zalcitabine in the NRTI class. It's not available in South Africa. It has long been registered elsewhere, so it's a drug that we don't have experience with. In the in the nucleotide reverse transcriptase inhibitor group, we've got tenofovir, which is one of our commonly used first-line agents. And then we look at the NNRTIs. We've got efavirenz, recently registered etravirine, and then nevirapine. Raltegravir is one of the drugs that is registered elsewhere, but it's not available in South Africa. And delavidine is one of the oldest NRTIs, but we've never really received registration locally. And then PIs, we've got lopinavir, which is one of the commonly used PIs, especially in second line, both in the private and public sectors. And then atazanavir, which is a drug that I'm going to concentrate on in terms of its place in therapy right now in the public and private sector. Ritonavir is commonly used as a booster for most of our PIs. And then darunavir is one of the drugs that I'm going to focus on today as one of the newly registered products within South Africa. Nelfinavir, saquinavir, indinavir, I mean, they are there, but they're not as popular as all the other ones. So their place in therapy is really limited right now. And then the last three are drugs that are not currently available in South Africa, but are registered elsewhere. And then enfivatide, which is Fusion, is a fusion inhibitor, long there as well, registered elsewhere. We've used it in very limited cases locally. So it remains unregistered. And then there are co-receptor inhibitors. The one that has received registration overseas is Maraviroc, which is a CCR5 co-receptor blocker. And then there's also Vicriviroc. So that one is, the ones that I've highlighted in green are actually still in investigational stages elsewhere. And then integrase inhibitors, we're going to focus today on Raltegravir, which also received registration about a year ago in South Africa. And then Elvitagravir is also within trial stages. So this is really what we have to play around with, but I think the talk today is really going to look at the clinical aspects of these drugs, but also the positioning locally. So we know they are there, we know they are used, but what is the appropriate place for the use of these drugs in the private sector? So the other milestone in terms of HIV management is really that we now can offer our patients once-a-day dosing. So a patient can really take one tablet a day and be managed properly. So this is really progress compared to 1997, where patients had to take, I mean, if you count there, it's 28 tablets. And remember, these patients are not only taking antiretroviral therapy, some of them will have co-infection with TB, they'll have other infections where they need management. So if you add 28 to the other tablets that they are taking, then it becomes really a very huge burden in terms of the pill count. So I think we are excited about these developments, and most of you will know that Etravirine was actually registered about a year ago, and the sales, we've got an MSD person here who can actually confirm that it really did very well. And it's actually quite interesting that some patients who are treatment experienced, they also want the 1 tablet a day. They don't understand that it's not for everyone, but I mean the excitement about having to take 1 tablet a day is such that everyone wants to be on it. Recently, I think beginning of this year, we've had 2 generics registered for Etravirine. So in terms of driving pricing down, unfortunately, as I stand here, I will not just talk about clinical, I also look at the costs. So in terms of driving the prices of antiretroviral therapy down, we always welcome the new registrations of generic products. So the advantages really of Etravirine is that it's a once daily dose, and we know it's a combination of Truvada, Stockrin, or tenofovir, emtricitabine, and efavirenz, and it's used as a first-line regimen product. And as I said, generics are already available, which actually assists in driving the cost down for our first-line regimens. So if we look at our local guidelines in terms of first-line and second-line therapies, we know that they are almost up for review. So we need to look at what is going to happen with the review of the guidelines, because they were published in 2008, and I think a lot has happened, and therefore we need to update them so that we can position some of the new drugs in the newer guidelines. So if you look at our recommended first lines, sorry Leon, I'm only focusing on adults in these. So in pediatrics, the guidelines for peds are slightly different from here, because abacavir is one of the important NRTI products that need to be given to pediatrics. So our recommendation from the Clinician Society guidelines is that we should be starting patients on NRTIs for first line combined with dual NRTIs. And the first one looking at Truvada. I know in the public sector, you don't have the combination of Truvada. So patients will be put on lamivudine, tenofovir, and efavirenz as 3 separate agents. And then we've got zidovudine and lamivudine. Sorry, the emtricitabine is not supposed to be on there on the other ones. It was copy and paste, and unfortunately, it let me down. So lamivudine is only combined with zidovudine. Emtricitabine is combined with tenofovir. So, I mean, we know those are older combinations, and we've actually had fixed dose combinations for a while now. And also the abacavir, we've got a fixed dose combinations in the form of Kyvexa. So if you look at those guidelines, we can safely say the commonly used combination is tenofovir, emtricitabine, and efavirenz, or lamivudine. So lamivudine or emtricitabine in the public or private sectors. But abacavir, as much as it is a good alternative, it remains, it is not cost effective. So I think most of you will be aware that the cost of the combination of abacavir and lamivudine is sitting close to 1,000 rand just for that, before you actually add the NNRTI. So it makes your first line regimen to be more than 1,000 rand. And if you look at our average cost for first line agents right now, it's sitting at around 500. So it actually doubles the cost of your first line if you use abacavir. And then if we look at our second line ARTs, we know that it is our ritonavir boosted PIs. So the recommended PIs will be Atazanavir, lopinavir, and saquinavir. I don't see a lot of people putting patients on saquinavir. I think it's just there as an alternative for those patients who may not tolerate Atazanavir and lopinavir. But lopinavir is the PI that is used currently, and it is also basically because patients have been on lopinavir, and there's just more experience in terms of lopinavir in practice. But I'm going to touch on Atazanavir just to look at the benefits of Atazanavir and also look at the limitations in terms of why is it not used as often as lopinavir, especially looking at the benefits that it has. So if you look at Atazanavir, it is another protease inhibitor. The recommended dose is you can either boost it or unboost it, but in instances where you give it with Truvada, you will have to boost it. And usually it will be treatment experienced patients where the recommendation is that it needs to be boosted. So when you boost it, you give it with Ritonavir. So boosted, you give 300 milligrams with 100 milligrams of Ritonavir. And it comes in 150 milligram tablets. So you will give 2 tablets and 1 tablet of Ritonavir, which actually decreases your pill burden. Because if it's a patient who's taking Truvada and Reataz, which is actually now we've got even generics. So Reataz was the brand name for Atazanavir. Now we've got generics that have since come into the market. So you will be taking 3 tablets as a patient combined with Truvada. So it's 4 tablets at night compared to a patient who will be on Truvada and Lopinavir, Ritonavir combination where it is 2 tablets BD, meaning that the patient has to take 2 tablets twice a day, and if you combine it with Truvada, then it will be 5 tablets. And in terms of dosing frequency, I mean, Atazanavir is better because then it's once daily dosing, so your patient will be taking the 1 set of tablets at night. So they will be taking 4 at night. Common adverse events, really the one that is mainly reported is the hyperbilirubinemia with or without jaundice. So some patients do present with jaundice. And you can get nephrolithiasis, skin rashes. And the only other, I think, it's whenever a drug requires some food, you need to adjust for this, and that it really becomes a problem for a patient because then they must make sure that there's a meal before they can take tablets. So it becomes a disadvantage when you have got food requirements. But I think overall, if you look at Atazanavir, it is a good second-line alternative. And unboosted Atazanavir cannot be administered with tenofovir, efavirenz, or nevirapine. Okay, so luckily we don't usually see those combinations often of NNRTI and PIs. We used to see them, especially in those instances where patients would have lactic acidosis and therefore the NRTIs are not used. So the most important one is the Truvada. So where tenofovir is used with Atazanavir, it will always be boosted with Ritonavir. So it's important to remember. So like I said, just to summarize the benefits, it's fewer adverse effects on lipids than other PIs, especially when unboosted, because once you boost it, the Ritonavir actually nullifies those good benefits. So it's once daily dosing and low pill burden compared to your commonly used Lopinavir-Ritonavir combination, and good GI tolerability. So we find that most of the patients who don't tolerate Lopinavir-Ritonavir combinations well, then they are switched to Atazanavir and they tolerate it much better. And the signature mutation, which is that I50L, is not associated with broad PI cross-resistance, which is something also very important. Now, when we look at our newly registered products, so I've got 3 that I'm going to focus on, and I'm just going to give you a brief update on the ones that are not registered but are in the pipeline. I mean, it's just a few, but I know the pipeline is quite huge for the different companies, but I'll just focus on the few that are appearing, especially in the international guidelines. So the first one is Darunavir, which is Prasista, marketed as Prasista in South Africa, and it was registered in South Africa in August 2010. So it's just over a year old. If you look at the indication, the registration in South Africa said Prasista should be used in combination with 100 milligrams of Ritonavir, meaning it must be boosted, and with other antiretroviral agents, so not as monotherapy, and is indicated for the treatment of human of HIV infection in antiretroviral treatment experienced adult patients such as those with HIV-1 strains resistant to more than one protease inhibitor. So clearly, this is not for first-line use. The registration in South Africa is not for first-line use. And then the second one is Raltegravir, which is marketed as Icentris. It was registered last year in March 2011. It is indicated in combination with other antiretroviral therapies and also for treatment-experienced adult patients with evidence of ongoing resistance despite being on treatment. So this one also, it clearly states that these patients are actually I mean, the drug is actually used for treatment-experienced patients. So the registration in South Africa is not for naive patients, it's for treatment-experienced patients. And then Etravirine, so this one as well, it's also in combination. As you can see, all of them, not as monotherapy, for treatment-experienced patients in the adult arena. So starting with Darunavir, I think we've got a little bit of experience because it was one of the first registered out of the 3. So the first trial that I'm actually showing you there is looking at Darunavir used in patients who were treatment naive. Because remember, it is used somewhere else as a first-line agent, but in South Africa it is not registered for that indication. So what they did, they looked at Darunavir, and it was compared to Lopinavir, okay? It was given once or twice daily, Lopinavir, Ritonavir, both in combination with Truvada in a randomized open-label non-inferiority trial. The study enrolled 689 ART-naive participants, and at 48 weeks, it showed that it was non-inferior to Lopinavir. So this was not a superiority trial, it was just to show that it is non-inferior to the commonly used PIs. And among those participants whose baseline the viral loads where there were more than 100,000 copies, the response rates were lower in the Lopinavir, Ritonavir arm than in the Darunavir arm. So in summary, when they looked at 96 weeks, they found that virologic responses were superior to those of Lopinavir. So when I try to explain what Darunavir is to somebody who is not in the HIV world, I always say it's an extended spectrum PI. So if you think of where you would use it, so you would use it in instances where a patient has actually failed Lopinavir, Ritonavir, because it is actually superior in terms of the virologic response that you would get. So also looking at 2 trials that resulted in Darunavir being registered for treatment-experienced patients. So there are those 2 trials where they were randomized and they were phase 2B trials. The criteria, the eligible participants to this trial were patients who had detectable viral loads, so viral loads of more than 1,000 copies, who had prior treatment with PIs, NNRTIs and NRTIs, so that shows prior treatment, so they are not naive, and who had at least 1 primary PI mutation at screening. So that says these patients were already failing therapies, so they were really treatment experienced with failures, and were on a stable PI-containing regimen at screening for at least 8 weeks. And the analysis included 318 subjects in the study, and in the one study, and then 319 in the other, and who had completed this study in the 24 weeks. So the results really show that the proportion of patients who had reasonably undetectable viral loads, even though 400 is still, so that's their cutoff that they used. Because usually when we look at undetectable viral loads, we look at less than 40 copies, but they use their cutoff as less than 400. In their arm receiving Prevista, they compared to the comparator arm, and they found that those patients had a 63% virological response. So it's important to note that, 63% is a good response, but it's also not like wow. So it's good compared to those patients who received the comparator PI, which was sitting at 19%. In addition, they also looked at the log drop. So there was a significant log drop from baseline, which was close to 2 log decline in the arm that was receiving Prevista, compared to the other one, which was just 0.5 log decline. And the mean increase of the CD4 count as well, just looking at how patients did, was higher in the arm receiving Prevista than in the comparator arm. And if you look at it, it was around 92 cells per millimeter squared, millimeter cubed, which is quite good. So this is just a summary of the outcomes. So if you look at the virologic responders and those who failed, which was about 26% of all patients who were included. And if you look at the description, so looking at the lack of initial response, so those are patients who did not achieve at least a confirmed 0.5 log drop from baseline at week 12. So those were about 9.9. So if you look at the ones that never, I mean, we got rebounds, and also we got those who were never suppressed. So the ones who have never, who never received, I mean, reached full suppression were those who never got the one log decline in the 24 weeks. So if you look at darunavir, the recommended dose currently is that of 600 milligrams BD, boosted with ritonavir, and it must be administered with food. And the type of food, it can be KFC or it can be sushi, doesn't matter. It does not affect the exposure. And then renal impairment, no dose adjustment is required in patients with moderate renal impairment. And I think it's very important for us to always note, because there are special groups of patients that always need special mention, especially those who are in renal failure and those who are on anti-TB meds. So this is also just looking at tolerability and toxicities related to the drug. So we know it's a PI, and we know GI side effects are usually common. And as such, you can see there's diarrhea, there's vomiting and abdominal pain. But remember, we've also mentioned that if you look at lopinavir, I think it's the one that gives you most of the GI side effects. So the other ones are better tolerated, especially when we just reviewed Atazanavir as well. So if you look at those who did get these side effects, they were ranging at around 2.3, but it's actually interesting that the other comparator PI was worse, so you will know that it's probably lopinavir. And then vomiting as well and abdominal pains. So I've just summarized the side effects. So it has got a sulfonamide moiety, and we know that patients who are sensitive to sulfonamides, the sulfur component of the drug, they can actually get skin reactions, and they can actually also develop Stevens-Johnson syndrome, which is a more severe form of reaction. So you get hepatotoxicity as well, diarrhea, nausea and vomiting, headaches, hyperlipidemia, like all other, because remember PIs, this is really a general PI-related side effect profile. And if you look at drug interactions, some of you will know about the cytochrome P450 enzyme system, and we know that CYP3A4 is the one where the bulk of our drugs are actually metabolized. So if a drug interferes with that, it will definitely have drug interactions. So darunavir and ritonavir are both inhibitors of this this isoform. And because of that, so as an inhibitor, it means when they are co-administered with drugs that are metabolized here, then they will inhibit the breakdown of those drugs and result in those drugs becoming toxic. So it's very important. So those drug interactions will be there, and you need to just take cognizance of that. So if it's administered with warfarin, for example, it will reduce warfarin. And if you look at patients who are on clarithromycin for NEC, those cases you will find that the clarithromycin is going to be increased, and therefore you can get clarithromycin toxicity. So you may want to use maybe the alternative, which is azithromycin. And in cases where patients have got hyperlipidemia and are using rosuvastatin, you must remember most of the statins that are used for the management of hyperlipidemia are actually contraindicated in patients receiving PIs. So patients who are on Simva and lovastatin, we usually say you cannot give them PIs. So rosuvastatin is one of the statins that is commonly used in patients who are receiving statins. So the interaction that you see there shows you that you will actually increase the rosuvastatin area under the curve, and therefore you can have toxicities related to that. And you must know that patients who are receiving statins, they often complain of muscle aches and stuff like that. So this needs to be taken into account so that you don't dose rosuva too high for the patient to actually reach toxic levels. And for us, because we are in South Africa and we know TB and HIV co-infection is a reality, darunavir, ritonavir is actually contraindicated with rifampicin. And we know the role of rifampicin also in the cytochrome P450 enzyme system. It is a potent inducer of that system. So because they are all working in that space, so they interact. And the reason for the interaction is because rifampicin, like I said, is a potent inducer, and therefore it reduces the plasma levels of darunavir and making it subtherapeutic, and therefore it is not ideal. So this is very important for us to note. So that was just Darunavir. I'm going to discuss later on the placing of this. And then now we look at Raltegravir. If you look at Raltegravir, it is one of the newest classes, because remember Darunavir is part of the PI family. Raltegravir is an integrase inhibitor, and because the integration process itself is a multi-step process, it actually inhibits the strand transfer part of that process. It is a new class, like I said. There are several trials that have been done for Raltegravir. I'm going to just highlight the findings and what in the group of patients that were included in these different trials. So the first one is really the BENCHMRK trial, where naive patients were included, and then we've got the BENCHMRK study, which included the treatment-experienced patients. And then I'll discuss in brief switcher, where patients were actually switched from efavirenz to Raltegravir. And then the REALMRK, actually the REALMRK trial, I noticed that one of the centers that were used were in South Africa, and Mariette Botes and Stephen Miller were one of the principal investigators locally. So looking at the BENCHMRK trial, the focus here was to look at the safety and efficacy of Raltegravir compared to efavirenz-based combinations. And this was in treatment-naive patients. So the study evaluated Raltegravir, so it was given 400 milligrams twice daily. We know the dose of efavirenz, which is 600 milligrams at night, and it was in combination with tenofovir emtricitabine. So this is the real feel for us. This is our first-line regimen. So when they looked at these patients, they found no significant differences between Raltegravir and efavirenz in the percentage of patients achieving an undetectable HIV viral load, although the increase in absolute CD4 counts was greater in the Raltegravir group compared to the efavirenz group. So if you look at the other benefits that were shown by Raltegravir in this study, is that it provided a rapid and durable improvement in virological outcomes, and it was statistically non-inferior to oral efavirenz, which is our commonly used NNRTI, at both weeks 48 and 96 in the ongoing BENCHMRK trial. And if you know, I mean, we all know that with our efavirenz, we do get derangement in our lipid profiles. So they found that lipid profiles were less affected with Raltegravir than with efavirenz. The second trial that I looked at was the BENCHMRK trial, where now they looked at Raltegravir, and they were looking at patients now who were treatment experienced. So the patients received Raltegravir plus optimized background regimens with placebo plus OBR. So you get a patient who's getting Raltegravir plus optimized background therapy, which could be different other drugs, and then placebo, and then optimized background therapy as well. So when they looked at these patients after 48 weeks, they found that patients in the Raltegravir arm were significantly more likely to achieve an undetectable viral load compared with those in the placebo arm. And the best virological result occurred in those patients who received Raltegravir with Darunavir and Fusion and Fuvetide. So it just shows that also you needed to have a specific, so in those patients who were on specific background therapy, there were even better outcomes where Darunavir and Efavirenz were added. So remarkably also was that 50% of those receiving Raltegravir with no other active drugs also achieved an undetectable viral load compared with only 2% of patients receiving placebo plus OBR. So it showed that there was, I don't even want to think about monotherapy, but it showed that this drug was highly effective even in the absence of those active drugs. So it still showed good viral suppression. So the BENCHMRK trial and other trials led then to the approval of Raltegravir for treatment-experienced HIV-infected adults with detectable viral loads and who had resistance to multiple antiretrovirals. Another interesting one was the switcher study. This one, they just wanted to look at tolerability of Raltegravir compared to the commonly used NNRTIs, and in this case, it would be Etravirine. So they took patients, and these patients had been on Etravirine, and they were well controlled on Etravirine, but then they randomized them into two groups. So these patients received either Raltegravir or Etravirine, and then they switched over. And all they wanted to assess, I mean, it's a small trial with 57 participants, and only 53 of those 57 were analyzed. But they just wanted to have a sense of whether patients preferred Raltegravir better than Etravirine. And half of the patients previously on a stable Etravirine on a stable Etravirine regimen preferred to switch to Raltegravir after double-blind exposure to Raltegravir for 2 weeks. And then there was another trial, the SPIRAL study, which was a 48-week multi-center open-label trial in which there were HIV-infected adults with less than, so they had undetectable viral loads, at least for the previous 6 months. And these patients were on PI-boosted regimens, and they were now randomized into, a PI-boosted regimen and also into a Raltegravir on one-on-one. So these were also switched from this ritonavir boosted PI to Raltegravir, or to continue with their PI boosted regimen. So you either went on Raltegravir or you were switched. So you either stayed there or you were switched or you continued with your PI. So 273 patients were assigned to switch to Raltegravir, and the rest were continued. So 134 continued, and they were included in the analysis. So at 48 weeks, 89.2% of the Raltegravir-based therapy patients and 86.6% in the PI boosted regimen, patients remain free of treatment failure, which is something I think that was the primary endpoint. They wanted to see if you will remain free of treatment failure at the end of the study period. So that was achieved. In patients with sustained virological suppression on ritonavir-boosted PIs, switching to ritonavir-boosted PIs and to Raltegravir demonstrated non-inferior efficacy. So whether you were staying on the boosted PI or you moved into Raltegravir, you still achieved a benefit. But the important thing is that on the Raltegravir arm, there were better lipid profiles that were observed. So the last one is the REALMRK study, which I said, I think some of it was done locally. So it was a multi-center, also international trial, including South Africa. As you can see, it was North America, South America, Dominican Republic, and South Africa. And we had 2 of our clinicians participating in this trial. And it looked at, this one was particularly looking at race and gender. So the enrollment targets were female, and also they looked at black patients. So the categories of treatment, it was a very diverse cohort that looked at treatment-experienced patients who had either failed first lines or had failed second lines. So it was really a group of very diverse patients, and some patients were actually naive. And the findings at the end of the trial was that it had potent efficacy regardless of gender and race. So you can give it to females and you still get good outcomes. And it's not a racist, it's cool, it will help you whether you're black or not. So that's what they found. And then Raltegravir was generally safe and well tolerated, so it was a great thing. And overall, 15% of patients discontinued Raltegravir for whatever reason, and 17% of those were women versus 13% which were men. And we don't know whether men discontinued because there was anything wrong or they just didn't like the drug. And then of the black patients, 14%, and then 17% were non-black. And also they just looked at the pharmacokinetic parameters, and they looked at at the fact that there was no significant effect or based on gender or race. So if you look at now the pharmacokinetic criteria, attributes for this drug, it is primarily metabolized by glucuronidation, and as such, because it does not use the cytochrome P450, it means it will have fewer drug interactions, which is a good thing. So that is a plus for it. It displays distinct viral dynamics compared with other ARTs, with a more rapid onset of action and a greater reduction in second phase viremia. So if you look at the rapid decline in viral loads compared to the other ARTs, Raltegravir has become quite favorable in that effect, and that it requires twice daily dosing, has got a low genetic barrier, which is a negative for it, because drugs that have got a low genetic barrier, it means that they develop mutations quite quickly, and therefore it's a problem for us. So because of that, it has got relatively limited use with other dual NRTI combinations. So if you look at its place and where it really performs best, it's with other active agents and usually in the salvage space. So the advantages currently of Raltegravir is that it has got a good virologic response, which is non-inferior to our well-known friend Etravirine, and it has got fewer drug-related adverse events and lipid changes than Etravirine, and there's no food effect, so you don't have to worry whether you've eaten or not eaten, and fewer drug interactions than PIs or NNRTI-based regimens, because it does not fiddle in the cytochrome P450 space. Disadvantages: twice daily dosing. Ideally, we would want to have a drug that you can give once a day for ease of use for the patients. And because of its low genetic barrier to resistance, it becomes a negative for it, whereas we know that our boosted PIs have got durability and have got a higher genetic barrier to resistance. And currently, there is no data with NRTIs other than Truvada in ART-naive patients. And it also increases the creatinine kinase, myopathy. It causes myopathies and rhabdomyolysis. And in rare cases of severe reactions, patients did develop Stevens-Johnson's, which is something that can be quite fatal for some patients. And some of the patients have developed systemic hypersensitivity reactions with rashes and constitutional symptoms. So it really is for those patients who can tolerate it, but in some instances it can really cause problems, but generally well tolerated. So route of administration, it's given orally. The dose is 400 twice daily, and I've just touched on the side effects. And as we said, it is does not respect, it does not really, it's not a racist and it's not a chauvinist. It's really a very nice drug. It loves women and it loves black people. And moderate hepatic impairment and severe renal impairment, no clinical significance there. And if you look at it currently, unfortunately for Leon, it is not approved in pediatric patients. But in peds, they don't have to get registration, they will use it anyway. Okay. And if you look at resistance to Raltegravir, if you get complete loss of antiviral activity with a single mutation, which is something that we are aware of, especially in the NNRTI space, where with our nevirapines and Etravirine drugs, you get one K103N and you've killed the whole class. So here it's the same thing. So you can get just one single mutation, and then you've lost the viral activity of the product. So you've got those different mutations, and these alone or in combination with other mutations can actually confer that resistance. And they've looked at specific ones that are called signature resistance mutations in patients failing both Raltegravir and Elvitagravir, which is the unregistered relative of Raltegravir. And you can see that most of these were associated with Raltegravir, and the other ones, the last ones, the E92Q and the S14. I don't know if anyone ever remembers all the different mutations, but me, I don't. So I will always refer. So those different ones were associated with the Raltegravir. And other resistance integrase mutations were observed in patients failing Raltegravir and/or, so those are the other ones, but they had little effect. So you need to really worry about the signature ones where you know that the antiviral activity of the drug is actually lost. Now the second one, the third drug that has been newly registered is Etravirine, which is an NNRTI. It's a second generation NNRTI. It received approval on the basis of a pooled analysis of DUET 1 and DUET 2. So this was for treatment experienced patients. So if you look at the patients that were included here, it was treatment experienced patients with documented NNRTI resistance and patients who had more than 3 primary protease inhibitor mutations and who had detectable viral loads of more than 5,000 copies per mil. These patients were randomized to receive Etravirine 200 milligrams or placebo in BD, plus they were on a background regimen that included Darunavir. And over and above, they also received Enfervitide. So if you remember, there was that similar combination with the Raltegravir as well. So the primary endpoint was the percentage of patients with confirmed viral load that is less than 50 copies, which is undetectable, and time to loss of virologic response. So just a summary of the findings. So in those patients who received Etravirine with the background regimen of Darunavir and Enfervitide, it was found that they demonstrated superior virologic responses than placebo, and the background treatment experienced patients at 4 weeks who were on placebo were not. Okay, so if you look at it, it's 61% for those patients on Etravirine compared with 40% in the placebo group. So that was statistically significant. And when analyzed by selected baseline characteristics to look at, so then they did a subgroup analysis to say, okay, let's look at the baseline characteristics of the patients that were included. They found that Etravirine group, it still achieved higher responses than those in placebo group, irrespective of whether they were on Enfervitide, irrespective of race, irrespective of disease characteristics, or previous NNRTI use. So as you are aware, this is another NNRTI, but another extended spectrum, because for patients who have actually failed an NNRTI, you can still use Etravirine. So baseline viral load, CD4 cell count, Enfervitide use, and number of sensitive background ARVs were predictors of response in both treatment groups. Nevertheless, Etravirine provided added benefit in each subgroup. So it is approved at a dose of 200 milligrams BD, and it's used mainly in treatment experienced patients. So they've done a small study where they've also looked at patients who received 400 milligrams once daily compared to 600 milligrams noctare of efavirenz, where these patients were treatment naive. Remember, I said it's only registered currently for treatment experienced patients using the pooled data analysis of the DUET 1 and 2. So here it was 79 patients and 78 participants were randomized to Etravirine and efavirenz arms respectively. And when they looked at 48 weeks, 76% of the Etravirine recipients and 74% of the efavirenz recipients achieved plasma HIV viral load levels of less than 50 copies. So the difference there is 2% between the Etravirine group and efavirenz. But we know the major side effects of efavirenz, which is neuropsychiatric side effects. So if you compared the groups in terms of tolerability, especially looking at side effects that are related to the neurological system, so it was found that more of these patients were in the efavirenz group, and I think we are well aware of that. And these results suggest that Etravirine can actually be used as first line. But unfortunately, more data needs to be generated, and I think there are larger trials that are taking place, and therefore, once those have been reported on, it will probably be registered for naive patients as well. So the dose is 200 milligrams twice daily, taken orally, and it also needs to be taken with food, which is always a bit of an inconvenience. But for patients who have got renal impairment or who have got some mild to moderate hepatic impairment, there is no need for the dose to be adjusted. And side effects really are related to rashes that could also result in Stevens-Johnson syndrome. They also get hypersensitivity reactions and also nausea. Drug interactions. So it is an inducer of the CYP3A4, and as you see, once you see that, you know then it's going to interact with most of the drugs that use that system, and it also inhibits the CYP2C9 and CYP2C19. So those are smaller, so it's only drugs that use those specific isoforms that will be impacted, but otherwise the big one is the CYP3A4. Now, if you remember, we spoke about Etravirine, and we spoke about clarithromycin when we discussed darunavir, and we spoke about the fact that because of the inhibition, you can actually get increased levels of clarithromycin. So here you get the opposite, where you get reduced levels of clarithromycin. So this is relevant for those patients who need to receive it as part of the MEC treatment. And also clarithromycin can also impact the Etravirine levels by actually increasing them. So you need to consider giving those patients azithromycin. Rifabutin, exposure to Etravirine may be altered. So remember also rifampicin may also reduce the levels of Etravirine, because we said rifampicin is a potent inducer of the cytochrome P450 enzyme system, and therefore it will impact those levels and you can get subtherapeutic levels. Resistance. I think it's important to look at resistance to Etravirine, especially because we've got experience with the registered NNRTIs, particularly the nevirapines and efavirences of this world, where we know that they've got a very low genetic barrier to resistance. This one, fortunately, has got a higher genetic barrier to resistance than the two that we've got experience with. So there are 17 resistance-associated mutations with Etravirine, and their effects are most significant when 3 or more are present. However, there are individual mutations that have got different impacts on the susceptibility to Etravirine. And if you look at the ones that have been listed there, those ones have got the highest impact. So for this one, if you get a Y181L or a Y181V, I think it's actually I, so I and V. So you find that there you don't actually need to get 3 or more. You can actually get fewer, and you can have antiviral susceptibility lowered. So it's very important. So K103, which is our favorite friend when we talk about efavirenz and nevirapine, has no effect on Etravirine susceptibility, which is a good thing. So if you look at the 3 drugs, so they've been used together in combination. And I think in South Africa, the cases that I've seen, especially in the adult space, where patients have got multi-drug resistant HIV, they've failed first-line regimens, they've failed their second line, and now they need third-line agents. We've seen patients who are actually on all 3 agents. So there is actually some good data to actually confirm or affirm the reasons for using them together. So this study looked at the combination of darunavir, Etravirine, and Raltegravir, and they said it showed efficacy in the treatment of patients who were treatment experienced, and 90% of patients achieved undetectable viral loads, which are viral loads below 50 copies per mil at week 24, and by week 48, 86% had actually reached undetectable viral loads. So it's quite good. So we know that these now offer our treatment experienced patients who in the past had no alternatives, an alternative of 3 new agents that you can use for third line. I think most of you will remember the times when we used to give patients dual PIs, because we didn't have really much to give once the patients have failed the regimens that were available. So other studies have also shown similar effects of these 3 novel drugs. So I've given you some references for this trial that looks at the combination of the 3. Now, if you look at, locally we have not reviewed the drugs in terms of our guidelines because our guidelines are still 2008 guidelines. So in the next review, I'm hoping that the positioning will be clear. So just looking at the American guidelines, looking at their first-line regimens. So they've got their preferred regimens, and preferred regimens are regimens with optimal and durable efficacy, with favorable tolerability, and also toxicity. The toxicity profile is good and they are easy to use. So the first one there is similar to what we use, which is efavirenz, TDF and FTC, which is the Truvada Stockrin that we use. But if you look at their guidelines, they also include PIs as first line. So you can use Atazanavir that is boosted with ritonavir with Truvada. And darunavir also is given once daily there with Truvada. And Raltegravir is also given as a first-line alternative there. So for pregnant patients, they use Aluvia with Zidovudine 3TC combinations. So this is America. If you look at the European guidelines, they are not that different because also they look at the preferred, so their NRTI backbone will be Truvada emtricitabine, with alternatives being abacavir and lamivudine. But obviously with abacavir, there's also that caution that if you've got patients with very high viral loads that are more than 100,000, you need to almost not use it. So in South Africa, I think the major limiting factor for abacavir is still the cost, but we do have also patients starting therapy at very high viral loads, which would actually preclude the use of this agent. So the third agents would then be Atazanavir, ritonavir, darunavir, efavirenz, and Raltegravir. So if you look at this, then it means 2 of our newer agents would then be positioned as first-line agents elsewhere. And for me, the fear that I have, I will hear from the experts in the room as well about using these drugs in the first-line regimens and having nothing to use in third-line regimens, because once you use them up front, then you almost are using them prior to the other ones. Then looking at alternative regimens for the Americans, so the preferred ones, so these are alternatives. So you can actually use efavirenz now with abacavir as an alternative, which is similar to what you see with the European guidelines as well. And then there is a new drug, which is Raltegravir. Raltegravir is an NNRTI as well. I'm just going to touch on it briefly because it has become now part of the international guidelines as an alternative in first line. And there is also, so you can either use it with Truvada or you can use it with abacavir lamivudine. So they also have PI-based regimens there. 5 minutes. Okay. So regimen selection, what do we look for when we choose regimens? So we look at comorbid conditions. So whether a patient has got cardiovascular disease, especially when you look at drugs like abacavir, chemical dependency, so patients who have got other issues, psychiatry, liver disease, TB. I think for us, TB is such a big thing, and therefore interactions with our TB meds become a very difficult thing when we need to manage patients. Potential adverse drug effects, you always want to have a safe regimen. Potential drug interactions with other medications, because most of these patients will be on other medications. Pregnancy or pregnancy potential, so if you are planning to fall pregnant or you are pregnant already, and then result of genotypic drug resistance testing, so where you already know that a patient will only benefit from this and that. And also gender and pretreatment CD4 count if considering nevirapine. We know the cutoffs, the 250 and 400. And then the core receptor tropism assay, this is now overseas where they're using drugs like Maraviroc, where you need to make sure that the patient will actually respond to the drug, and you actually test for the tropism first. And then patient adherence potential. So you need to make sure if you've got a patient who's doing shifts, what regimen are you going to give them? Are you going to plan their regimen such that they take it at this time, so, and also the drugs that you're going to include there to take into consideration the shifts, and also convenience, the pill burden, dosing frequency, and food and fluid considerations. So now let's get to the money. So we've heard all the good things about the 3 newly registered products. So if you look at Icentress, it's sitting at $897, and this is now a Raltegravir without adding the Truvada. So if you add Truvada to Raltegravir, if it was to be used as first line, okay. But in South Africa, we know it's currently being used as salvage. So what we see in the private sector for those patients who are treatment experienced, so you must just combine all the 3 costs, and that's the cost of the regimen, okay, and add some dispensing fees as well. So that is the cost of our third-line regimens right now. So if you were to use Raltegravir as first line, I mean, we've had requests already for Raltegravir use as first line. So that means your first line regimen will be over 1,000 Rand. Just to give you some background, currently our first line regimens are sitting at just around 500. And we have seen major moves in the second line regimen space, where we used to pay just over 1,000 Rand for second line. But because Aluvia's price has dropped so dramatically, we are now sitting at just over 500, close to 600 for our second line regimens. And the other contributing factor is the introduction of generics into the market. So now if you were to look at that and then look at Icentress as a first line agent, then it means we would actually be doubling the cost of our current first line regimens. And then Interlens, fortunately it's not registered for naive patients, but it is used in combination, so it's not used alone. So the cost of Interlens, you must always look at it considering the fact that it will be used with Icentress and with Persista. And then we see Persista as well as a recommended first line alternative overseas, and the cost is sitting at 738. So it would make the cost of our first line regimens just around 1,000 Rand. Just now a summary of NNRTI and the class advantages, especially looking at our first line regimens. So we know that the class advantage is that they've got longer half-lives. The class disadvantages are that they've got a greater risk of resistance at the time of treatment failure and potential for cross-resistance. So you fail one, you fail them all, and then skin rashes, and they can also get Stevens-Johnson's as well, and a potential for drug interactions because they use the cytochrome P450 enzyme system for metabolism. And you can also get transmitted resistance, especially with that you get it more with NNRTIs than with PIs. Looking at our PI-based regimens, and I think for us, particularly in the second line space, because we don't use them in the first line, so these have shown good virologic and immunologic responses, but we know, especially with our friend Aluvia, that patients really complain of GI side effects where they've got diarrhea. But there's always an alternative. And I don't think I gave you the positioning in terms of Atazanavir. In the guidelines, it's there, but if you look at the funding, because it's also slightly more expensive than Aluvia, so it has lost preference because of that, but it's still a very good alternative in terms of once daily dosing and stuff. So that is that, and fewer GI side effects, and also you can also give it once a day. Drug resistance to most PIs requires multiple mutations, so high genetic barrier to resistance. And most PI-based regimens, they include ritonavir. And clinically significant interactions are seen with ritonavir boosted than with that. Just to touch base on Maraviroc, I'm not going to dwell into it. It's an entry inhibitor, CCR5. Most of the vast majority of patients harbor the CCR5, especially during the acute or recent infection, but some of them will actually convert into SCRX4, and therefore you need to always check so that you know that the drug is going to work. Advantages, I mean, it's not available here, but you can just have a glance at the major advantages. It's non-inferior to efavirenz, fewer adverse events, but it requires the test before you can actually use it, and more patients treated with maraviroc discontinued due to lack of efficacy. So you can have a nice drug that does not really give good clinical outcomes. So I'm not going to dwell on that. The last one is Raltegravir, which I think we should be aware of. It's not here yet, but I think it will come soon. So it's an NNRTI, once daily dosing. Elsewhere in the world, it's also co-formulated with efavirenz. So the combination, which is similar to Atripla, is Complera, and it's registered, I think, in the US. Compared with efavirenz, it has got fewer discontinuations for CNS adverse events, so the patients don't develop the CNS side effects, fewer lipid effects, and fewer rashes. The only problem with it is that patients who have got viral loads that are more than 100,000, you don't get you've got poor virologic response, and more NNRTI and 3TC associated mutations at virologic failure with this one than with regimens containing efavirenz. Okay. So if you look at it, also the disadvantage is that there's food requirement and absorption depends on lower GI. So if a patient is taking antacids and stuff like that, you can actually impact the absorption, and it's contraindicated therefore with PPIs, and it's also associated with depression. So there is an element of psychiatric association similarly to efavirenz, and it must be used with caution when co-administered with drugs. With drugs for patients because it can give you torsades because of the QT interval prolongation. So here, 3 mutations have been identified as associated with this, and those are the ones, and the resistance profile appears to be more robust than the ones that we know. So I think I've tried to rush through it, and yeah, so that was my talk.